So we'll move now to the competitive presentations, we have 4 of them, and we'll start with the presentation by Martina Frech-Dörfler, Evaluation of Tolerance Towards Ureteral Double G Stents in Children, an Unmet Need. Thank you.
Thank you very much, dear chairs, dear colleagues. Thank you very much for the opportunity to present our study here in this session. Ureteral double J stents are commonly used devices in urology as well as in pediatric urology. They often lead to a decreased quality of life caused by irritative symptoms. To assess these symptoms, the ureteral stent symptom questionnaire, the USSQ, was developed in 2003 for adults. In children, we know little about the tolerance. A standardized method to assess stent-related irritative symptoms are lacking, and we don't know if the tolerance is similar in younger and older children. So it was our aim to assess the tolerance of children towards double J stents, evaluating especially the irritative symptoms in regard to the different ages. Further, we aimed to raise the awareness of the need for a standardized evaluation method. We conducted a prospective observational single-center study between December 2020 and February 2022 of patients treated with uni or bilateral double J stents. The patients were followed after 1 and 4 weeks, and if necessary, then every 4 weeks until stent removal. The used stents were either magnetic or non-magnetic. The non-magnetic stents had to be removed by cystoscopy under general anesthesia. The magnetic stents could be retrieved in an outpatient setting with or without an analgous sedation. The decision about the used stent type was made interoperatively due to the underlying condition. We created a questionnaire which was adapted from the former mentioned USSQ. It contained questions about pain, medication, voiding problems, hematuria, and daily life activities. The questionnaire was adapted to 5 different age groups: infants, toddlers, younger and older school children, and adolescents. Pain was assessed using the visual analog scale, face pain scale, or the QSS, depending on the age of the child. A total of 20 patients could be included. None were lost to follow-up. Median age was 2.5 years, with a peak in infancy. Most of patients were male, and in 75%, the patient had got a magnetic stent. Most common indication for double J stent insertion was laparoscopic pyeloplasty. All patients received an antibiotic prophylaxis. The mean indwelling time was 4.5 weeks. More than the half of the patients suffered from irritative symptoms, mainly located in the bladder. The irritative symptoms and the voiding problems were more frequent in patients with magnetic double J stent. There was a significant association between age and the reported pain score, which means that the irritative symptoms increased with age and were highest in the group with the adolescents. Despite this high irritative symptom rate, there was only 1 patient which was absent from school for a longer time. In all other patients, the stent had no impact on the daily life activities. So our study shows that irritative symptom rate is similar to that reported in the adult population. There are few studies which assess complications of indwelling double J stents in children. None of them have evaluated the irritative symptoms as a primary objective so far. The symptom rate increases with age. Here, an observer bias cannot be excluded, as in infancy, the evaluation of subjective symptoms is difficult, and we have to rely on the caregiver's assessment. The daily life activities are less impaired in the pediatric patients, and the complications were of lower severity, keeping in mind that a stent reinsertion in children needs general anesthesia and so corresponds to a complication Clavia-Dindo grade 3B. In conclusion, we can say that the current study lays the groundwork for a standardized evaluation of ureteral stents in the pediatric population. The results indicate a high rate of irritative symptoms, which increases with age. Our questionnaire is the first step to a sensitive assessment of the tolerance in children with indwelling double J stents regarding the different ages. And the next step in standardizing the use of double J stents in the pediatric population involves the validation of our questionnaire through a large-scale multi-center study. Thank you very much for your attention.
Thank you. Is there any question in the audience? Maybe to start, are you sure, how well can you compare the pain between very young babies and older children or adolescents? Because you use different questionnaires. For babies, for example, it's more the parents that are responding to the questionnaire. So I understand that using this questionnaire, you can compare the pain within that age, specific age group, but can you really compare using different questionnaires between age groups?
For the different ages, the pain we assessed with the pain scale, which is assessed for the different age groups. There is the face pain scale, the QSS. So we use this scale, and they are specific for the age group. So I think, yes, we can compare it with this, but we can't rely on the subjective symptom because the babies cannot tell us how they have pain. But in a way, with this standardized scales, we can compare it in a way, yes, I think.
So what would be the potential interventions to alleviate those symptoms which you detected?
Yes, first, there are several types of stent. I think we have to differ in further studies. We saw that the magnetic stents have a higher irritative symptom rates than the non-magnetics. This could be a fact. And then there are some medication treatment we can give to the children in the different ages, and we also assessed the medications to see if we can improve the treatment medically to relieve these symptoms and to give them a better time with the stent.
Thank you very much for this pioneer work. It's very hard to generate high-level evidence for new techniques, new treatments, and frequently we have to wait years or even decades for randomized trials, and here kick in registries, and we are very curious to hear the preliminary data from the International Registry on liver venous deprivation, Gaëtan Jolia from Lausanne presenting.
Oops. Sorry, it's not a good one.
All right, thank you very much, dear moderators, dear colleagues. I'll present today the first results from the International Registry on Liver Deprivation. So what is liver deprivation? It's the simultaneous portal and ipsilateral hepatic vein embolization. And the goal of this procedure is to maximize the liver hypertrophy before a major hepatectomy. It's still a very recent procedure. It's been invented and published in 2016 by the team of Guyot in France. And as it is very recent, an international registry was created in 2020. So the aim of this study was to assess the outcomes after liver venous deprivation in patients included in the Euro-LVD registry. So for this, we did a retrospective study of all consecutive patients included in the registry. The study period was from the registry implementation in 2020 to end of March this year. We collected pre-op characteristic data on liver regeneration and post-procedural and post-operative outcomes. For the methods, the future remnant ratio was calculated. It's defined as the future liver remnant volume based on CT divided by the functional total liver volume. And we excluded in this functional total liver volume the volume of the tumor. We also calculated the standardized FLR ratio, which is the FLR divided by the total estimated liver volume. And we use for the total estimated liver volume the formula published by Vote et colleagues in 2002 from the MD Anderson. And this formula used the body surface area. Here are the results. So 8 international centers participated from France, from Switzerland, from the US, Italy, the UK, and also Austria. There were 223 patients in the registry. Included in the study were only 216 patients. They all underwent liver venous deprivation except one who had a technical failure. It was not possible to embolize the right hepatic vein. And then 160 patients underwent partial hepatectomy. So 56 patients dropped out. Mainly it was due to tumor progression in 13% of the cases. And the insufficient liver growth was only 4%. If we look at the preoperative characteristic of this cohort, it's quite a standard cohort for this procedure. Not a lot of cirrhotic patients, only 1%. The main indication for hepatectomy was colorectal liver mets in 57% of the patients. 1/4 of the patients had prior local regional liver therapy, so it could be chemoembolization, radioablation, or microwave ablation, for example. And 59% of the patients underwent neoadjuvant chemotherapy. If we look now at the LVD procedure in itself and also the results of the hepatectomy, the success rate for LVD was quite high, 99.5%. So only one, as I told you before, only one patient did not undergo LVD due to a technical failure during a right hepatic vein embolization. The complications after LVD was 14 cases, and it was mainly hemorrhage in half of these patients. The duration of LVD was, the median duration was 130 minutes. In median, we waited 41 days between LVD and surgery. The complications after a major hepatectomy were 48%, so concordant with the results of the literature. And the rate of post-op liver failure was 3%. So only 5 patients had liver failure in this cohort. If we look at the main results, so here you have the graph comparing the preoperative FLR ratio. So before LVD, the median was 33%, and after LVD, you can see that the growth was significant until 46% in terms of FLR ratio. If we calculate this ratio for 15 days, to see that it's quite a quick hypertrophy, you can see that it was 41% already after 2 weeks. And we also calculated the median kinetic growth rate, that was 3.5% per week, to have a comparison for PV, so for portal vein embolization, it's around 2.5% per week. And it's been shown that if you have a median kinetic growth rate lower than 2.4% per week, it's a risk factor for liver insufficiency. If we look at the survival, so the overall survival comparing colorectal liver mets, HCC, and cholangiocarcinoma, you can see that the median overall survivals were good in this cohort, 69 months in median for liver mets, 43 months for HCC, and surprisingly for cholangio, 56 months. That is quite high. And regarding the disease-free survival, for all indication, it was under 2 years. So to conclude, in this cohort of patients, there was a high technical success rate for LVD. Only one patient was not able to have hepatic embolization. It shows a significant hypertrophy with a median kinetic growth rate of 3.4% per week. And major hepatectomy after LVD appears to be safe if we look at the complication rates. I thank you for attention, and if you want to join the registry, it's still open.
Thank you very much. Do we have questions from the audience? I imagine that Christian Tusso has a question.
I'm a bit disturbed by the 50% complication rate after the hepatectomy. So I think it was mainly bleeding complications. That's correct?
Mainly what, sorry?
Bleeding, hemorrhagic.
After operation?
Yes.
No, that was after LVD.
Okay. But what were the complications after surgery?
After surgery, 48%.
Yeah, but what were they?
Overall complications.
Even minor
and major.
Okay. All right.
Yeah. And major complications, it was, I think, around 15 to 20%.
Okay. Because it would be interesting also to compare this group to patients who had no portal, deprivation, and to see whether it has an impact at the end, because of course you block also the outflow, and you might have potentially more congestion in the liver and potentially more bleeding during the surgery. So it would be interesting to compare
that's a good point.
So this introduces my question to you. Let me challenge you a little bit. So to assess new clinical treatments, you have to apply the PICO framework. So if you would have to design a randomized study, so I don't understand the intervention. The I is the venous deprivation, but what would be the patients, the P? So the patient cohort include, what would be the comparative treatment, and most importantly, what would be the primary outcome measure?
Good question. Regarding the patients, I think we need to take patients with indication with major hepatectomy and who had a low future liver remnant volume on CT. The comparison for the moment, the gold standard is still portal vein embolization, so I think it's important to take this one as a comparison. And for the main objective, it's a good question. If we take overall or disease-free survival, I think overall survival is more important than disease-free survival. So I think that would be the main outcome I would take to compare both, because that's what matters in the end.
Thank you very much for very clear and short answers and a fantastic presentation, Gaëtan.
And we'll move to the next presentation from Zurich, Joana Ferreirinha, Compatibility of Family Planning and Surgical Training in Switzerland. Thanks a lot.
Dear audience, it's a pleasure to present the results of our study with the title Compatibility of Family Planning and Surgical Training in Switzerland, a national survey study comparing female and male surgeons. These are the beautiful sunrise and sunsets at our hospital. Most of you know these skylines due to long days and long training. These circumstances during optimal childbearing age can lead surgeons to delay family planning and risking infertility and pregnancy complications. There are worldwide studies that report about inequities between female and male surgeons when it comes to family planning. In the last few years, large survey studies reported about fewer children, higher use of assisted reproductive treatment, higher rates of pregnancy complications, higher rates of miscarriages, and higher age at first pregnancy in female surgeons. In Switzerland, so far, no data exists about infertility and pregnancy complications for surgeons. The fact that 60% of med school graduates are female, but only 38% of board-certified surgeons indicates barriers from women towards a surgical career. In view of the literature, this study aimed to investigate the prevalence and constraints of part-time work and family planning among surgeons in Switzerland. In an anonymous online survey, we questioned part-time employment, family planning, and the use of assisted reproductive treatment. Male surgeons were asked to answer questions about ART and pregnancy regarding their partner's pregnancy. There was no possibility of identification of participants. Surveys were sent via email to all surgical fellows working in a surgical department in Switzerland. Included were board-certified surgeons or those being within 1 year of completion. And answers were compared between female and male surgeons, as well as between female surgeons and female partners of male surgeons for the questions about ART and pregnancy. 600 emails were sent and 375 surveys were completed. Response rate was 55.1. After exclusion of 67 surveys due to a board certification not meeting inclusion criteria, 380 participants were included for analysis. Proportion of female and male was balanced. Let's talk about the results. Characteristics of male and female surgeons did not differ. They had the same current age and age at med school degree, the same time to board certification and time to second specialty or subspecialty. Also, the time of certification and subspecialty and activity did not differ. When we look at the results of part-time work, we can see that both genders had a high interest in working part-time, about 70% of them. Even so, only a few realized it, 18% and 37%, which was a higher rate for female. Duration of part-time employment was also longer in female, 1.8 versus 5.5 years. Reasons for part-time work related to family or health were higher for women. Despite the wish for part-time work, 71% of male and 50% of female surgeons never worked part-time. And around 80% of them never spoke about this wish with their superior. Most mentioned reasons for not addressing were concerns about training prolongation, a negative career impact, and a negative stigmatization. Finally, the results about family planning. Female surgeons less frequently had children, 70 versus 45%, and more often had the desire to have further children, 37 versus 71%. They were older at birth of first child compared to male surgeons and compared to female partners of male surgeons. Over half of female were of advanced maternal age, meaning over 35 years. They more frequently delayed pregnancy due to training compared to male, 23 versus 74%. Female surgeons more often had a time to conceive longer than 12 months, which is the definition of infertility according to the World Health Organization. Furthermore, they had higher rates of ART, 4 versus 14%, compared to female partners of male surgeons. Rates of preterm delivery, miscarriage, and obstetric complications did not differ. Interestingly, many female surgeons perceived their gender as a negative career influence, which was only the case in 5% of male surgeons. In view of these results, we conclude that female and male surgeons in the age range of fellows reach the same education level at the same time. However, at the expense of childlessness and infertility. Part-time work is popular in both genders, but realization is rare. And there is a high rate of negative perception of gender among female surgeons. Thank you very much for your attention.
Thank you very much. So it's a very nice study and questionnaire, very well designed and scary data, in fact. Did you have a look also at the outcome or the results based on the location of the responders? I mean, the French-speaking area, German-speaking, and also the type of hospitals they are working in, more university or more canton or more smaller hospitals. Yeah. Did you look at that? Or?
No, we didn't look at that.
Okay.
We thought about it, but at the end, we didn't do it. But it's a good idea, yeah.
Yeah, disturbing data. Thanks very much for presenting this. If you had 3 wishes, what are the top 3 which you would like to ask your department chair and the politicians to realize immediately to remediate this situation?
So I think, of course, awareness for this topic has to be there, and the possibility of part-time work when you want to raise a child. But for me, my personal opinion is the most important thing is to create a more focused training. So in Switzerland, training is very long and very vague. And if it would be more focused and faster, people could think about family planning at an age which is younger. And reduce working time then, maybe.
And you might start by increase awareness of the problem and maybe send your study to all department heads once published. Yeah. Fabian Grass.
Thank you very much. I enjoyed that talk. So a bit similar question than Martin. So what do you think needs to be done mindset-wise get better conditions for female surgeons? Because you showed it, the length of the education is the same for male and female. So do you think female surgeons are ready to add 2 extra years to get the title, and or what should be done? What is your takeaway from that?
Yeah, as I said, I think if the whole system would be a bit different, this problem wouldn't be there.
But do you think female surgeons would be ready kind of to delay their education for that reason?
Yeah, the data shows that they're not ready to delay because they have the same time. I think that this would not be the right solution, but it's one solution, yeah, that they delay their training.
And Fabian, why only female surgeons? So wouldn't be male surgeons also allowed to take some time off to take care of children and help their women?
Yeah, of course.
Sorry, yeah, of course, but I was talking about the actual pregnancy now. So to take that time off, yeah, sure, Martin. So I agree with you, but.
And I agree with you that we couldn't assume pregnancy, of course. Okay, last question, please.
Yeah, actually my comment was just made. So if we split the work for the child and the caretaking better, it's not an issue of a female to have the perspective of reducing work if we split it more.
Thank you.
Thanks very much. So please publish soon. Very interesting data, and don't advertise the paper on social media, of course.
Thank you.
Last but not least, also a very hot and controversial topic, what is reality for rectal cancer treatment is not the case yet for the opposite part of the GI tract. Is it feasible, reasonable, and safe to apply watch and wait programs after neoadjuvant treatment for esophageal cancer? Please, Mrs. Gerber.
So thank you very much for the introduction, and good afternoon, everyone. In the next few minutes, I invite you to explore this alternative treatment strategy in esophageal cancer, the watchful waiting. Esophageal cancer is well known as a highly malignant and severe disease with a rising incidence and associated with high morbidity and mortality. The treatment of this disease is a challenge and often a battle against time and comorbidities. Nowadays, standard of care, the trimodal therapy, consists of a neoadjuvant therapy followed by resection. But we all know the esophagectomy is a highly invasive surgical procedure associated with high morbidity and mortality. So it's not astonishing that researchers and clinicians all over the world are looking for alternatives, so-called organ-sparing approaches, such as the watchful waiting, a path that prioritizes quality of life, minimizes unnecessary intervention, and yet, hopefully, promises comparable survival outcomes. And to analyze exactly those survival outcomes was the aim of our study. In the first step, we compared patients with a clinical complete response, whether they underwent standard trimodal therapy or watchful waiting. In a second step, we analyzed the subgroup of watchful waiting regarding their further management, whether they had recurrence or not. Therefore, we analyzed data from the Inselspital in Bern with all patients diagnosed with esophageal cancer from 2014 to 2021, and analyzed their records until 2023, so we could ensure at least 2-year follow-up period each. As a clinical complete response, we defined, similarly to pre-existing literature, no evidence of vital tumor cells in the restaging biopsy. In our hospital, it's the standard of care that the patients with esophageal cancer receive a neoadjuvant therapy with a radiation of 50.4 gray and a combined chemotherapy. After that, a restaging is performed, and if there is no sign of a persistent tumor, the so-called clinical complete response, either esophagectomy is performed as the standard trimodal therapy, or the resection is withheld and a routine follow-up consisting of repetitive endoscopies, imaging, and clinical examination is performed. In this watchful waiting, further therapy such as a salvage esophagectomy is only performed in case of tumor recurrence. In total, we analyzed 350 patients, but excluded roughly 250, mainly due to no clinical complete response. Finally, we included 96 patients, whereof 45 had standard trimodal therapy and 51 watchful waiting. The watchful waiting group, 29 had tumor recurrence, whereof again 12 were treated curatively. First, we compared the standard group versus the watchful waiting. Regarding the standard demographics, there was a difference with the patients in the watchful waiting group being in a slightly worse general condition with a slightly higher Charleston comorbidity score. Furthermore, there was more adenocarcinoma in the trimodal therapy, but besides that, no further differences in the standard demographics. Now we looked at the subgroup of watchful waiting. As I said, 22 had no recurrence, 17 recurrence treated palliatively, and 12 recurrence treated curatively. Here we had, regarding the demographics, only a slight difference regarding the age. Besides that, no further differences were noted. Of the 29 patients with a tumor recurrence, 21 had local recurrence only, 5 systemic disease, and 3 both of them. Reason for curative versus palliative treatment were tumor extent and size and location of the recurrence, patient's general condition, and not least, patient's wish. Now, let's look at what's interesting finally, the overall survival. In the blue curve, we can see the patients which underwent standard trimodal therapy. Unfortunately, but very realistically, 5 years after diagnosis, around half of them are dead. Even worse is this curve. If we look at the watchful waiting patients which had a tumor recurrence and were treated palliatively. But let's look at the positive and promising curves now. Patients in a watchful waiting which had no recurrence, orange, or in the pink curve, patients in watchful waiting with recurrence treated curatively. This leads us to 2 main findings I want to point on. First, there is the same overall survival in patients in the watchful waiting whether they had no recurrence or a recurrence treated curatively. This is so far interesting that prior studies often only pointed on the overall survival or the tumor recurrence as their endpoint. But this finding supports our opinion that a recurrence in watchful waiting does not imply a devastating prognosis. Contrariwise, excellent outcomes can be achieved if detected early and treated aggressively. Next finding, the overall survival was better in patients with watchful waiting if they had no recurrence or a recurrence treated curatively than in those who underwent the standard therapy. This is even more interestingly if we think about the fact that the patients in the watchful waiting group were slightly in a worse clinical condition. Now, for sure, our study has its limitations, started with a retrospective design and then individual distribution into the groups. Also, there was a relatively small sample size. Furthermore, we did not yet differ between the tumor types, even if we know that there are major differences if they have adenocarcinoma or squamous cell carcinoma. Now for the future, it's important to improve both the detection of the clinical complete response and also the follow-up procedures so that we can bring all those patients from the green curve up to the orange or pink one. Now to conclude, watchful waiting is gaining more and more importance in the clinical practice and justifiably so. For patients with a clinical complete response, it might be a better alternative. Especially for those which are weakened after the neoadjuvant therapy, these findings are essential. It gives us the relief to operate those patients immediately after the neoadjuvant therapy. If they have a clinical complete response, we can allow them the time to recover and to improve their general condition for a potential salvage esophagectomy later. But I know we are all surgeons in here, so no worries. The surgery has still its very important role in the treatment of esophageal cancer, but maybe it should be withheld for patients without clinical complete response, which are still most of them, or for those with a tumor recurrence in the watchful waiting concept. In future, the fight against esophageal cancer might not only be fought just with a scalpel and chemotherapeutic drugs, but also with an understanding of follow-up concepts, reading between the lines, and a sense of acting in the right moment. Thank you very much for your attention.
Thanks so much to you. Do we have questions? If there's no immediate question, I would like to start off. Who should take the decision, in fact, after complete clinical response, if to go for watch and wait or surgery? So we have potential benefits for either strategy, and there was a recent publication, the BJS, where a Dutch group performed a discrete choice experiment among patients, and interestingly, patients were ready to trade off worse overall survival for having a better chance to preserve the organ. So how would you make the decision making for this very complex and difficult decision?
Thank you for the question. I think this is a very important point, and I think luckily we have these interdisciplinary tumor conferences where we can discuss the patients, where we can discuss which option we can bring to them. But finally, it's the decision of the patients. We operate on them, and esophagectomy is a very invasive surgery, and I think it's very important to inform those patients properly about both ways we can go, if we can go both ways, about both ways, about the advantages and disadvantages of both.
For the rectum, we know that we have to monitor them after a complete response very accurately with combined clinical, radiological assessments. What's the minimal recommendation for follow-up of these patients?
Yes, unfortunately in the esophageal it's not so structured yet. We are also doing some research on how to actually in a moment we do endoscopic examination with endosonography and endoscopy every 3 months, and CT scans every 6 months, clinical examination also every 3 months for at least the first 2 years.
And who's doing the endoscopy?
The gastroenterologist.
Is it always the same person, and does this matter? If it's not the same person?
In a dream world, yes, but unfortunately, no. Like in the clinical practice, it's not. We try to have them all at the center. We try not to give them already in the follow-up in smaller hospitals, but it's not always the same gastroenterologist.
Is there a usefulness to add systematic biopsies of the area, despite the lack of endoscopic evidence of tumor?
We do always the biopsies at every endoscopy because just inspectory, it's very difficult to say, is this just the ulcus from the therapy? Is it yes, or is it tumor? We do always the biopsies.
So let me get back to my question because I was not satisfied with your reply.
Sorry, I tried to help you.
I know you squeezed in. So I understand that you explain to the patients prior to a major surgery the different alternatives. So this is pretty much common sense and our obligation. But how do you explain those very complex situations to the patient? Should we use video material? Should we pre-educate the patient before the consultation? Should we check what they understood from this very complex information? Because here you can't just explain and then ask the patient, do you want to go for A or B?
Yes, good question. I think it's not one right answer to that, but I think it's important. We try also to see those patients not just at the restensic the first time. We try to already see them before we start with the neoadjuvant therapy, then during the neoadjuvant therapy to a bit understand how they are, how they understand us, and to build a relationship. And then we already give them then some information about potential therapies. And for sure, we should use some like visual material, and they don't have to decide at this time, at restaging. We can give them like maybe 1-2 weeks, which they can think about it, come back again, and do a combined informed content then for the either which arm we choose.
Okay, so this was really tough, and we also had lots of input from the BJS editorial team, so it's not our decision. It was so tough that we decided to distribute a first and a second prize, and because we didn't know until this session who would win, the team needed to print lots of different diplomas, as you can make in your calculations. So to get to the point, we have two winners. The second prize with 1,000 goes to Bern for the excellent study on watch and wait for esophageal surgery. And I think we have both prize winners come up directly to make one nice photo. So first prize goes to Dreamly, Zurich. So please come up here on the floor, and a big hands.
And still stay, there is one more award to give after.